Alright, so we're going to go ahead and cover our fluid balance and electrolytes along with acid-base disorders. Um, just a quick little thing before the video starts, I'll make it brief. So again, we're kind of learning it as it goes, so correct anything that is incorrect. We'll go ahead and get started. Right? So fluid balance, right? We're just going to do a quick little review, a little physio review, right? So there are a couple different ways to look at our fluid balances, right? They typically can come from our entire body, right? We have our cells, and then we have what's in between the cells and the blood vessel, right? So most of our fluid, as mentioned here, 40% of body weight, it could be 60, it could be, 50, 60, kind of, it just depends on the weight of the person. It's, the bigger the person you have, the more weight, but most of our fluid is contained inside the cells within the body, right? One big thing to note that's going to help out later down the line is that potassium is the most abundant solute, ion, whatever you want to call it, just something that is suspended in water and diluted in the cell. It's the most abundant in the cell, right? And then we have our blood vessels, which this little part right here, as mentioned, is our extracellular fluid. So this is our cell, right? Whatever's inside is intracellular. Pretty clear and nothing complicated about that. But extracellular is two different subclasses, as mentioned right here. So we have our intravascular space, where our blood vessels is in, and then we have our interstitial space, where it's like the middle. It's like our middle ground. And this can be called blood, it could be called plasma, it could be called serum, one or the other. It's all used interchangeably. But the most abundant here is typically going to be sodium. So potassium in here, sodium in here. And these are going to have, what's in here is going to have a very major, it's going to take a lot of stuff. Like it'll make a big impact on how fluids move. This one, what it is. All right, so we'll just go ahead and move down. As mentioned, this is just a quick review. This just points back to the top where, it's a picture just to give you a better idea. But again, the total fluid that we have, 50, 60, as mentioned before, and, the intracellular fluid within the cell that we have here, and the extracellular fluid. Typically, we're talking about this, but we can also talk about the interstitium as well. Big thing as well about the cells, right? So kind of coming down. So we see here triggers thirst reflex, right? So when you're dehydrated, that basically means that your tissues are shriveling up because they've lost fluid, right? Imagine the cell is like a grape, right? And we're getting dehydrated, which, how do they make raisins? They dehydrate the grape. So basically, our entire cell is starting to get shrunk. When the cell starts shrinking or turning into a raisin, our body has these things called osmolar receptors, which we're about to kind of go into a little bit, and they're going to detect a change. This change is going to stop. There's like a certain amount in here, right? The same way how there's a certain amount in here. And if it detects a change in volume or a change in solute size, it'll make a trigger for osmolar receptor action. And then from there, they'll say, oh my goodness, we've lost fluid and we're starting to turn into a raisin. We need more water. Or over here, it's the same way. We're having too much sodium in here. We need more water to dilute it, right? So that's just kind of to picture that in your head. So the control of fluid balance is typically done by three major things, right? We can lose fluids, mainly is the big one, right? Body fluids. We can lose electrolytes from those fluids. So the nice thing is that these two are basically interconnected. And then our acid-base balance is a little bit more, it's a little different, it's a little bit more up in the air, but regardless, it'll follow along here. So usually when we lose fluids, what do we think of, right? What do we think? Like
the route in which we lose fluid?
No, just like, what are examples of fluid loss? Burns. Vomiting.
Diarrhea.
Excessive suctioning. Diarrhea. Blood loss. excessive sweating, and here they are, excessive urine production. All those different things will cause us to lose body fluids, and what are inside those body fluids? Are electrolytes, right? And that has a major effect depending on, what's there's a lot of different factors that touch into this. Are they taking diuretics? Are they taking a thiazide diuretic? Are they taking a loop diuretic or a potassium sparing diuretic? Are they, what trauma do they have? What happened? So it has that's kind of up in the air, and there's a lot of variation to that. But the nice thing is that just think when we lose body fluids, what are in those fluids? Are electrolytes. And then what are some very important electrolytes that we typically have? It's going to be our sodium, calcium, potassium, magnesium, and there's more, but at least these are the big ones that we have to really care about. As for the acid-base balance, it could either be an accumulation of lactic acids, of potassium overtake, or it could be a loss of bicarbonate or other different things that are, I think calcium is also alkaline a little bit, so things like that. I might not be right about that one, but I know at least for sure bicarbonate, or NaHCO3, is alkaline, so if we lose too much bicarb for whatever reason, whether you're just too acidotic or whatever, that can trigger an acid-base balance, which will require IV therapy, typically. So from there, perfect. It is a little bit more. Yeah, perfect. All right. So yeah, calcium's just a little bit more alkaline in the context of the body. The same way how potassium is a little bit acidic in the context of the body. And then, indications, potassium chloride when losing too much potassium, or even when patients require it. Ammonium chloride can also be given, but that's a little bit more separate and it'll be talked about in a bit, so we'll go down. Osmolarity, right? That's typically how much of a solute is in 1 liter of fluid, and our typical body osmolarity is going to be 275 to 295 osmoles per kilogram. The big thing that I just want to at least put clear here is that sodium, as mentioned before, is the most abundant extracellular solute. So that has a lot to do with it. It could be it could be sodium, or it could also be glucose or urea. But the most important one that we really care about is sodium. And again, these are our solutes, not our solution, but our solute. It's what's suspended inside the solution. I would imagine that what we're going to talk about in a little bit, which are our fluids, are 0.9% normal saline, which I'm sure you guys have seen before. I would imagine, because that is an isotonic, which we'll talk about right now, that is an isotonic fluid. That means its osmolarity is around here, because it's able to move in and out nice and easy with no issues. It's not going to take fluid or it's going to give away fluid. They'll probably work with each other. So I would imagine just for a baseline, when we hear isotonic, it's probably around this much. I don't know if they'll come up in the test, but it's just something good to know. So we'll move down. So now, osmosis, right? So we learned about diffusion heavily in physiology. Now we learned about a specific type of diffusion, which is our water diffusion, better known as osmosis, right? So I did my best to kind of just give an idea of where is the blood vessel. These brackets represent the blood vessel, right? So if something is hypertonic, we could imagine that as super salty, right? Something like there's more rocks of salt in the blood vessel than there is outside. And what did we learn about water? What does water like to do? What's up?
Follows sodium.
It follows sodium. I mean, again, it could follow glucose or urea, but it mostly wants to go where sodium's at, because it wants to dilute it. It wants to be part of the party, basically. So if you were to give a hypertonic solution, you can kind of picture, as shown right here, like a bunch of little rocks, they're all right here. And this is going to cause fluid from, remember over here was the cell, the grape that we had over here, and over here was the blood vessel. This is going to want the grape, it's going to dehydrate because there's more rocks over here, more rocks of salt than there is here. So the water is going to go over here. And what did we talk about? What can losing fluid from this grape cause? Dehydration. So that's a big thing when you give cellular dehydration, which will basically make you dehydrated, make you want to drink water, which is what will trigger your thirst reflex. That's basically what it is. So when you give a hypertonic fluid, what can that be good for people that are having like an issue where they have too much fluid in their cells or in the interstitium, and we want to bring it to the vessels so we can pee it out later. What is that kind of more indicative of? What would we give this kind of fluid if we want to bring it from over here and put it in here? Patients with edema.
Yeah.
We want to use it because it's like a way to use a magnet. Like here's your magnet, and then here the magnet is, and all the water comes here. Then eventually it goes to our kidneys, and then we pee it out. And now we're kind of less full of fluid, and things are better. Blood pressure goes down, and like lessen the chances of heart failure. So now for hypotonic, right? Hypotonic. This is basically as close as to pure H2O. No extra solutes, no alkaline water, no, whatever water, different versions, just H2O. This is as close as we can get. And when you give that kind of fluid, if it's close to H2O, what did we talk about? Water likes to follow what? Sodium, yes. However, if it doesn't have as much sodium, like it is right here, where can it find sodium or potassium or anything else, any solute? Where can it find it? It's going to find it outside of the blood vessel, right? So you're going to give this hypotonic, so close to H2O, fluid for people that are very dehydrated because you give them the fluid, right? It's in there. And then now, because it's more, it's saltier because the grape shrunk, right? A little. So we want water to go over there to make it plump again. We want to make it like nice and plumpy and fat. And then the nice thing about isotonic is that there is no net change, so it'll flow in between each other with no big problems, which is pretty neat. I would imagine if one isn't full, it'll fill that one first, and then by the end, it'll equalize. So, one's down here, and the other one's up here, right? This is our extracellular fluid, or intracellular, vice versa, whatever. When you give an isotonic fluid, it will probably bring it to level, but it won't go over, nor will this go over. It'll move together. The whole point with isotonic is that you just bring them at a normal level. So everything gets sorted out and you don't cause problems. Pretty clear, right? Like it's just a quick update with our review for osmosis, right? So fluid balance, right? The biggest controller of that is our kidneys, right? I mean, after all, when you take in water, where do you usually lose it? You pee it out, yeah. So the biggest thing that is important is to know our renin, angiotensin, aldosterone system, right? And the nice thing is that we have a really good picture to show what's going on, right? So if we've covered a little bit of RAS, which is the short name of that, the RAS, and what's nice is that it's the way it's said, the renin, angiotensin, aldosterone system. This is what's triggered first, then second, then third, and then it's nice because it follows the flow. Renin's activated, angiotensin's activated, and then aldosterone is activated. So, it follows line in line. So you don't have to think about, oh man, which one goes first or second. It's in the name. So when renin discovers that the blood pressure is low, right? What is a way that our body can do in order to fix it for the time being?
Hold on to water.
Hold on to water, and what is something we can do to the blood vessel to increase pressure? We shrink it. So the nice thing is that renin activates angiotensin, which angiotensin typically does vasoconstriction. At the same time as angiotensin is activated, aldosterone is also activated. So this is a mechanical response. Angiotensin, it makes the vessel like small, so the pressure goes up. Our aldosterone, which we've already reviewed from our past exams, is a mineral corticoid. What did our mineral corticoids do?
Retain sodium waters.
Retain sodium, right? So when we retain sodium, we retain water. Exactly. So now we have a mechanical constriction of the blood vessel, which will increase blood pressure. We are also reabsorbing water into our blood vessels, reabsorbing sodium into our blood vessels, which will make water come back, and that's increasing the pressure even more. Because that's what we want in the event that we lower our blood pressure. We want to bring it back up. The only thing that needs to be known as well is that an additional stimulus that can be good or bad depending on the situation is that because aldosterone is making us take back a lot of sodium, what's something triggered in our pituitary gland, mainly the back of the pituitary, that comes out when it thinks that when we have a high level of solute, when there's a throw off of osmolarity. Thirst is a thing that happens with it, but what is the big thing? ADH. ADH is a big thing. Because imagine, to kind of give your mind a little run through, right? We talked about osmolarity, right? So if you are retaining sodium and you're not losing it by urination, what's happening to the osmolarity? It's going up. So because of that, now you're pulling water as well from our grape over here. Sorry, the photo was all the way up there, but the grape was right here. So now you're kind of dehydrating yourself, which will make you want to drink water, which is our thirst reflex. So again, it's just ADH thinks that you're dehydrated, so it will activate because it detects a lot of sodium in the blood vessel that's right here. That was all the way up there when the presentation. So it's just something that will happen. This evens out once we drink water, the blood pressure's back up, and it says, all right, that's enough. But, this can be helpful or it could be detrimental too, especially for people that are having a lot of stress, or overuse of mineral corticoids. That can cause you to activate ADH and all that stuff. So but long story short, fluid output is controlled by the kidneys regardless, and it's always detecting whether the pressure is low, and those are the two solutions. Make the blood vessels smaller or retain sodium, because if you retain sodium, you retain water. And usually it happens both at the same time. It's not like one does it and the other one doesn't. Like both are activated. I mean, after all, it's in the name. So yeah. So renin detects it basically. Angiotensin is a mechanical response. Aldosterone is a chemical response, in a sense, if you want to look at it that way, because sodium gets retained. And then that's it. And we can go ahead and move on. So, fluid balance disorders, right? I mean, when we lose a lot of fluid, what do we usually think? Like, let's say I just lost how much blood do we have? Like 5 liters on average. Mm-hmm. I just lost like 2.5 liters. What does that make me susceptible to? Shock. So that's one of them. What if I just haven't been drinking water in a very long time? Dehydration. So basically, fluid loss, whether you're just not drinking a lot of water, but you're kind of urinating, but I mean, ADH is going to try the best to hold it in, but you still kind of got to pee still. Or massive traumas like blood loss, burns, what we talked about earlier. So this will cause us to lose fluid, which will require us to get IV therapy, typically. The nice thing is that if it's mild, it can be given by mouth. I mean, that's what we want, right? Like the least invasive thing, just give them water. But if it's that bad, we need to give IV fluids. Now, as for what happens when we have way too much water, we're like too plumpy. What do we use? What was that thing that we talked about that we used to help remove water?
The diuretics,
Diuretics, yes. And again, there could be our thiazide diuretics, which mainly affect sodium. So that is a very possible thing to lose a lot of sodium using thiazide diuretics. Loop diuretics, biggest one that we know is furosemide or Lasix. That one we can lose a lot of potassium. So you always have to check potassium. You have to check sodium for our thiazide diuretic. And then also for our potassium-sparing diuretics, you also have to watch out when you give potassium because if they have a potassium-sparing diuretic, then that means they might be already high on it. So the last thing you want to do is give more. But that's getting further into it. Long story short, when we have way too much fluid, what's the best way to remove it? Just help them pee it out. And that's with the diuretic. When they're too low, give them an IV fluid or have them drink water. One or the other. It's right there. It's kind of clear and simple. So as for the IV therapies, right? We have crystalloids, and then we have our colloids, right? They're both gonna do big things regarding volume expansion, which will increase blood pressure, will rehydrate you, it will do things. But it's just how it's done that's a little different. And this box is just a review from all the way up there that was just talking about, how do you possibly lose fluids or GI, like GI ways through the GI to lose fluid, vomiting, diarrhea, laxative use, which is just diarrhea, and then suctioning from the gut. Right? If we lose too much, we can lose a lot of sodium, we can lose a lot of potassium and hydrogen ions, which will make us susceptible. What happens when we lose so many acids? Alkalosis. So that's something that can cause alkalosis again. So there's like a lot of different things going on. But there's also sweat, there's burns, there's hemorrhaging, there's excessive, urination, and then ketoacidosis, which is again part of just producing a lot of acids and makes you susceptible to acidosis. So moving down, so crystalloids, right? Crystalloids are basically what you imagine when you see a bag of like an IV bag up in the in the IV pole. That's like what you usually think about, right? And it's right in the name. It's replacing fluids and promoting urine output. And we'll know why they're crystalloids because they're so small. They're little crystals, they're just sodium chloride. It's just salt water, really, suspended in a liter of water, and that's at 0.9%, which makes it isotonic. But we'll get to it in a little bit. So, and the nice thing is that I did highlight this because this is a description of a hypotonic fluid, leaving plasma and moving to the interstitial spaces in intracellular fluid, right? So we had the big grape here. We have the middle, and then we have the blood vessel. So when you give a hypotonic fluid into the blood vessel, what did we say? It's as close to what as possible.
Water.
It's close to water as possible. And because there's not a lot of sodium or a solute or whatever in here, where is it going to want to go if there's some over here? It's going to want to go over there. So this is just to picture what's being said on the wall. As for, and this is just reiterating everything. The compartment that it goes to completely depends on the tonicity, which is another way of saying, I guess in a simple way, how salty is the water, or how osmolaric is the water too. So, this is where we're going to start having our review about hypertonic, isotonic. It's there, tonic, tonicity. So how osmolar is it? So moving down. So right here we have a big grid of various different IV fluids that are crystalloids. So the most recognizable one is our normal saline, our 0.9% NaCl. And we can see that it's isotonic. So what we want to do is, we already know that it's sodium chloride, right? So we want to picture that it's salty. Let's just say NaCl, 0.9%, normal, regular, isotonic, it's salty. And then we're going to have a hypertonic solution of 3% NaCl. So we have 0.9%, right? And we already said that's salty. That's 0.9. Mm-hmm. Imagine 3%. That's even saltier. So that one we could say it's saltier. As for hypotonic saline, it's half of this. It's half of 0.9. It's 0.45. So we said this is salty. So if it's half of that, that makes it less salty. So from there, now we also have an additional couple ones. It's lactated ringers. If I recall right, lactated ringers is used as a treatment as well for acidosis. If I recall right, but I am not too familiar with it. But lactated ringers is the same as normal saline, and Plasmolite 148 is also isotonic. So if we just picture our three isotonic fluids, they're going to be normal saline, our lactated ringers, or Plasmolite 148. And the nice thing is that there's two different plasmolites. There's an isotonic and a hypotonic. The nice thing is that the one with the biggest number is isotonic, and it's not going to go past 148, at least not that I've seen. And the one that's smaller, 56, which is half of it, or at least it's like, not really half, but it's lower than it. You can just see it as hypotonic, which right there it is. It's hypotonic. In fact, the saline 0.45 and the Plasmolite 56 are our only two hypotonic fluids. There is a very special one right here, but we'll go into it right now. So then we have dextrose, right? What do we typically use dextrose for?
Hypoglycemia.
People with hypoglycemia. So we'll skip this one for right now. But we have dextrose, right? Dextrose, I mean, it's sugar, but we'll say it's salty just to be consistent. Dextrose is already salty. It's 5%. All of it is 5% dextrose. But we'll just say this is salty already. And what happens when you put salty plus salty? Salty and salty, you're making it saltier. So now it's hypertonic. 5% dextrose with 0.2% normal saline. Right. So look, this, or 0.2, is even lower than 0.45. Right? So this is even more hypotonic. It's lower. It's as close to water as we can, without it really being water, than anything. So this isn't going to make a major change. We're just adding really dextrose, which is salty, with nearly water. So it's going to stay isotonic. It's not really going to make a big change. But now what about 5% dextrose, salty, with lactated ringers? It's going to be even saltier. Now it's hypertonic because we're putting salty and salty together. As for our 5% dextrose with Plasmolite 56. So the big thing that we should notice is that it's Plasmolite 56, which, yes, we do know it is hypotonic. It's not that salty. But it's not under that threshold like this one is, about 0.2. This one is 0.45, right? So it's still a couple more steps. It's like, I think, if I recall, like 25% or 0.25% more salty than this. So this is damn near water. But this is still kind of salty, right? So we're having salty with a little bit salty, not crazy salty, but it's still salty. So it'll turn into hypertonic. It's a little bit weird. Like, kind of like, hey, this isn't really consistent, but it's the best way to look at it because there's no other way to go around it. So always keep an eye out for that 0.2%, because if it's 0.2%, it's going to remain isotonic because you're not really making a difference. Now, what's special about 5% dextrose with water, right? Because it's salty with pure water, so it has no salt. The interesting thing is that this can be given for people who are very, very, very dehydrated. Because when dextrose is metabolized by the body, because initially it's going to come in isotonic, right? So it's going to go into the vein isotonic, and when it's isotonic, we learned it gives no net changes. It doesn't go up, it doesn't go down, it just goes in and it stays there. But as the body starts metabolizing the dextrose, that dextrose becomes water. So at first it's isotonic, but then what happens when you have water, right? So keep that in mind. And this dextrose, this salty dextrose, now turns into water after being metabolized. Now we have water and water. Just straight water. What is water?
It's
It's
hypotonic.
hypotonic, so it's gonna rehydrate you. I would imagine kind of fast. So that's it's interesting because it's the only one that can really. So keep that in mind. Dextrose with water, initially isotonic, but as it gets metabolized, it will become hypotonic. So now we're going to go with our colloids, right? So colloids are typically going to be proteins, which is can be seen as a solute. It's not sodium, but it's protein. So it's a big, giant macromolecule, kind of, right? And it's too big to leave the blood vessel. So, like, imagine here's the blood vessel, right? And a crystalloid is this little. It's only like this A. But a colloid is this wallet. It's all huge, so it can't really go through the the membranes. So because of that, and it's the fluid itself is isotonic, but this big molecule is like a giant rock of salt. Even though it's protein, again, we're just using salty as like a way to be consistent, so you know, like, oh, water's gonna go there. So this giant rock of salt is gonna attract water. So the main point of this, the main point of our colloid fluids is that they are to help out in retaining as much volume of water in the blood vessels as possible for the longest amount of time, right? So again, stay in the intravascular space, that big blood vessel we have over here. We don't really want it to be over here. And there is a possibility that you can become dehydrated if you think about it, because you're constantly going to be dragging water out of this big grape cell that we have over here, and it's going to go over here. So it's a possibility. I would imagine there's means to not let that happen, but it's big. And then it rapidly expands plasma volume because, again, this giant rock of salt is going to make the water go crazy and want to come here. So you'll like quickly regain it, because the main reason why this is given is for things like surgery, major trauma, major burns, things where you're losing a lot of fluid way too quickly, and your blood pressure is now going to go where? You're losing too much fluid. Where's it going to go?
Go down.
It's going to go down. And what can that do? It can kill the patient. So the whole point is to keep that fluid inside so we can go ahead and have the person have good blood pressure and keep perfusion up. So big thing, again, most of the time it's protein. So what's our biggest protein that we already have naturally in our own body? It's albumin. And again, it's used in surgery. Oh, I forgot to mention, it's also used in dialysis, because again, dialysis, your blood's going into a machine, we're losing fluid, and we need to keep it somehow. So it would be used in dialysis as well to keep that fluid in there, so you don't just, tank on your blood pressure and pass. So we have our 5% albumin, we have dextran, and we have hetastarch, and then we have plasma protein fraction. So albumin we know is a protein. We heard that so many different times when we were talking about blood and physics. Dextran and hetastarch, those you kind of have to just recognize them at very minimum. You don't have to memorize them, but you have to recognize them when it comes to fluid administration. And is this a colloid or a crystalloid? No, because, I'm sorry, it's not a crystalloid, because we already talked about crystalloids. Our normal saline, dextrose, lactated ringers, or our plasmolite, and that's it. This one, at least you could kind of make some connections. Plasma protein fraction, it's in the name. It's a plasma protein. So automatically it falls under the colloid family. So the whole point, again, increase osmotic pressure. If you keep osmotic pressure up, keep a good blood pressure. All right, so electrolytes. Now we're starting to get into a little bit slightly more complicated, right? So typically, don't pay attention to this right now. Just pay attention to this little box. Typically, electrolytes, the biggest thing that it's going to be about is that it's going to help us with nerve conduction and muscle function. But first and foremost, nerve conduction. Because before we have muscle contraction or function, we need nerve, function or whatever, conduction. So typically that's going to happen, but electrolytes also have a lot to do with water balance. The biggest one with water balance is what we talked about, like, our sodium. this is just going into, why we would give sodium chloride. It's kind of like a weird like thrust in here, but just for like just kind of starting to get into it. Um, our electrolytes are very big on this exactly. Nerve conduction, membrane permeability, water balance, which is mainly more for sodium than it is anything else. Sodium does the muscle stuff too. Don't get me wrong, but it's just very big on water balance. And then other functions. So sodium chloride, right? Mainly given as a supplement when we lose too many electrolytes. It's like the most. I mean, it's given in flushes. It's given. It's like it's like the universal fluid that is given to patients. So kind of straightforward, but typically it's being given to people who. What is our ranges of sodium? Without looking at here.
135, 145?
135, 145 milliequivalents per liter. Okay? So that's what we typically are going to have. So if it goes low, you just give them that. The only problem is that, like we learned in our endocrine stuff, if you give too much of the med that's trying to fix the situation, you run the risk of causing the opposite effect of what's going on. So you're treating hyponatremia, you're treating low sodium, and you gave them sodium chloride. But what if you gave them too much? Now you have hypernatremia. And when you're hypernatremic, there's a good likelihood, it's not direct, but there's a good likelihood that because of so much fluid was suspended, what are some complications when we have a lot of fluid? The edema, the heart failure possibility, your congestive heart failures and stuff, and pulmonary edema. As I mentioned, it's just fluid. Like there's just so much fluid that your body can't really work around it. So it's always, it's like a domino effect in a sense. So it's there. So the other one, potassium chloride, right? It's mainly given for potassium deficiency, mainly. It could also be given in some mild situations for metabolic alkalosis, typically for mild situations. But again, it's treating hypokalemia first and foremost, which is our low levels of potassium. What are our ranges? 3.5 to 5 milliequivalents per liter. Exactly. So biggest problem though is that adverse effects, GI irritation, right? So what if you're giving it through a pill? We said it's potassium is kind of acidic to the body, right? It's another acid, just like our hydrogen ions and our sodium ions are kind of acidic. So if you give a pill that's kind of acidic, that could cause, and you're putting it where there's already more acid, you can maybe make it more acidic, right? Because you're putting acids with acids. So that typically causes GI irritation. Same thing, if you're now giving them way too much potassium, you're running a risk of giving them hyperkalemia. And the biggest things too, you don't want to give this to people who are having chronic kidney disease because their kidneys can't remove the potassium. So it just stays in there. So now you run the risk of toxicity, which is another way of saying this, acidosis. And then you also shouldn't give it or be careful giving when you give it to patients who already have potassium-sparing diuretics. Because it's in the name. Instead of throwing out potassium, you'll keep it. And now you can have a big amount of sodium in here, potassium in here. Now you run the risk of going up. So you give them hyperkalemia. And as we've learned a lot with potassium, potassium is like almost the most important solute second to sodium, if not more important. Because what happens when we have high levels of potassium or low level, like extremely low levels? What happens to our heart in specifically?
It stops working.
It stops working because you start having bad conduction, and that can kill you. So we'll go into it in a little bit. Big thing to note, it's a big pill. Apparently it tastes horrible. Mm-hmm. So you typically, and again, we learned that it's an acidic thing and it causes GI irritation. So what happens when you have something that causes a lot of GI irritation? Also, the patient should be sitting up because we don't want to cause any esophageal discomfort. But what happens? What is something you can do to kind of chill out the acidity.
Give with food.
Give with food or take with milk. And they say it's like a giant pill, so I don't know. Let the patient know it's a giant pill. They call it the horse pill, which is kind of scary. So this is kind of scary a little bit because it's been a minute. I mean, it's been a minute with me for chem and all that stuff. But I mean, at least it should kind of be a little recognizable. At bare minimum, we should know what sodium bicarb is and sodium chloride. I mean, if we don't know these, then I don't know what to say because we have to know these by the bare minimum. Potassium chloride as well. Let's throw that one in there. It's in the name. At bare minimum, we should know these. And hey, look, it's 3 out of the 6 already. So we already know those. And just a little bit, I mean, even this one, calcium. We just have to remember calcium has 2 net charge compared to chloride. So there's going to be needing 2 chlorides to cancel out calcium. So now there's 4. Now we have disodium phosphate and sulfate. Our eights and ites, those are our polyatomic ions. So we just have to do a little review. The nice thing is that we have the chart, so we can go ahead and just review a little bit. But the best part is that we already know 4 out of our 6. So we just have to review. I don't know if the test will come up. Not very sure about that, but I would imagine it's here for a reason. Maybe give this a look. The good thing is that you can kind of start to remember phosphate. So it's going to be like PO. Remember, it always comes with. It always comes well. This one is HPO, so it's a little bit more other than just polyatomic. It has merged with hydrogen, but at least remember like sulfate SO. Okay, I remember that a little bit. And then it's in the name disodium, so we know we need 2 sodiums because there's 2 sodiums here to cancel out phosphate, so we know our charge is -2. So the nice thing is that there's a couple hints in the name.
This didn't come up in the MyLab. Did this come up for you in the MyLab? I didn't see this.
Well, I wouldn't know.
This didn't come up at all in the MyLab. I can make a.
It could make an appearance, but at least we should know these because they're in the name. I mean, at bare minimum, these 3. At bare minimum, because these are reoccurring. These other ones, I don't know about that, but at bare minimum, know these. And we just review constantly and all that stuff.
Yeah.
So, electrolyte imbalances, big thing that I'm not entirely sure of, but I'm kind of, it's up in the air, is that our calcium and magnesium levels, our ranges might not be this chart originally. The book is kind of telling me that for magnesium, it's 1.4 to 2.1. Now, every book will say something a little different. The biggest thing to know is that it's 1 to 2. Small range. I don't know if it's exactly, I asked the AI and it said this. But in another part it says this, what I crossed out. So I really don't know, but I'm more inclined to go off of this one because these values, the other ones are not, these haven't changed. 3.5 to 5 and 135 to 45 for sodium and potassium respectively. Those have not changed. But these, when I'm watching videos to practice, these sound more accurate than 4 to 11 and 0.8 to 4. The 1.4 to 2.1 sounds a little bit more consistent with what they're saying. Because this 4 to 11, that's a big jump. Especially for calcium. That's a major jump.
In the MyLab, I want to say it was like really far out of range. So it was kind of obvious that I want to say it was like 66 or something. So
yeah, no. So I would imagine, it would. That apparently, as a consistent thing, whenever they give you in NCLEX stuff or whatever, they usually will make it extremely high or extremely low. They won't, hopefully, do like hey, we're actually super close to here, so you don't know really.
There was a sodium one. It was like 133, but that one's easier to remember.
That one's not as deadly as like, for instance, potassium being at like 15 or something, because then the person's gonna die if that's the case. So now that we got that out of the way, the little disclaimer. Mileage varies depending on what ranges, but I'm just gonna go with the ones I have here in red. Calcium, right? We learned about calcium. We've learned it in the past 2 exams. When you have too much calcium, hypercalcemia. what's a solution for that? It's either we want to dilute it because we're too salty and we can dilute it with water. Well, not water, but like sodium, well, fluids, IV fluids. Or what was the naturally made hormone that is used by the body?
Calcitonin?
Yes, made by the thyroid, the calcitonin. So we could use those because calcitonin helps us pee it out. Well, first it puts it in the bones, but if it's too much, it'll help us pee it out, which is what we want to do when we're hypercalcemic. As for hypocalcemia, what are some things we can do to help bring up our levels? Vitamin D.
Calcium supplements, vitamin D supplements, sun exposure.
If it's that bad, you give them direct IV fluids of calcium. But if it's mild, you could go ahead and just give them vitamin D, like I said, put them outside, have them get the sun a little bit, and then give them calcium supplements as well. For magnesium, this one's a little bit more cut and dry. If you're hypermagnesiemic, you typically just want to dilute. There's no real other solution. You could, if I recall, there is a diuretic to help out, but I forgot which exact diuretic. For magnesium, if I recall right, it might be a loop diuretic, so your furosemide that gets rid of potassium could also possibly get rid of magnesium, but don't quote me on that because I'm not too sure, but I remember one of them could help out. But typically you could just dilute it, right? Just dilute it.
They're all crystals.
Yeah.
If you pour water on a crystal, the crystal dissolves.
Yeah, pretty much. Yeah. So imagine, like you have this in here, right, in the blood vessel. It's this giant rock because you're hyper magnesiemic. And then if you add water, you're expanding the volume so it's less concentrated when you get the vessel, plumped up because it's like all the fluid in there. Now it's less concentrated, which makes it less potent, which makes it bring it down just a little. And then if you're hypomagnesemic, then typically your only best bet is really just give them something, just nothing else. It's that kind of dry. As for our potassium, right? You could give them an array of different things. You can dilute it with hypotonic fluids. You can give them polystyrene, or how the heck you say it. That one is a special medication that makes you, in the bowels, exchange sodium for potassium. So instead of excreting sodium in your feces, you excrete potassium. And the nice thing is that it's called polystyrene or something like that, something similar to that. And that kind of sounds like strain, which is people that they strain when they're constipated. So kind of an idea. Its brand name has, I forgot what it is, but it sounds
K-exolate.
K-exolate, which sounds like, what was the connection?
Excrement.
Excrement. It sounds like excrement, which is poop. So
K, potassium?
Potassium excolate, which is excrement. Yeah. So potassium excrement. It's right in the name, so you can recognize it right there. Another different thing that you can also do is give them insulin, which is kind of like trippy. Why can you give insulin to lower a potassium level? So what did we say about our plumpy grape cell in here? What did we say all the way in the beginning? That potassium is what in the cell? It is the most abundant and most important in the cell. So that means it's an intracellular solute. So it has no issues going inside. All you need is just the key to open it. And what did we learn that insulin is for glucose? It's that key. So if you were to open the key, open the door with insulin, and glucose makes its way inside, maybe the door is open just a little bit enough for potassium to go inside. And if you're getting the potassium from over here in the vessel, because whenever you're hyper or hyper or hypo, that's referring to the blood vessel. It's not really talking about the cells or the tissues. It's talking about your blood, your serum level, your plasma. So that's what's important. So, as mentioned, like always, anytime there's insulin therapy, what is there a warning about? Hypoglycemia. So that is a potential risk when you do give for trying to lower that potassium. And then, other than that, I mean, it's like all of it. Dietary restriction. Your avocados, I think your bananas, your strawberries, if I recall right, bell peppers and stuff like that.
You say kale? I think she said kale.
I think, yeah, kale, like green leafy vegetables, if I recall right. Yeah, those you just chill it out for a bit. Will they make a big impact? I don't know, but still, chill it out. And then, as for if you're really low in hypokalemia, we just talked about it, potassium chloride. You could give the horse pill, or if it's that bad, you could give an IV fluid. So it's that straightforward. It's nothing wild. Sodium, same thing. Our range is 145 milliequivalents to 135. So well, I should have said that in the opposite, but you guys get the point.
Yeah.
Same thing. Dietary restriction. Chill out the sodium or dilute it with hypotonic fluids. That's really all you can do. Or you could give thiazide diuretics, which help you urinate sodium out more. Or you could give, well, I mean, that's kind of, there's not much else. If you're hyponatremic, you could give a hypertonic fluid. Because remember, what do we have? 3%? Almost 3%. Or you could also just give freaking isotonic. I would imagine giving 3% is like very specific. Like if they're dastardly low on sodium, I'll give it that. But
kind of depends on the question.
It depends on the situation. But we have hypertonic fluids for that reason too. And then sodium supplement, which is, I would imagine, maybe like a salt pill or something.
A little salt on your hamburgers.
Yeah, and that's it. Okay, so sodium. Now we're getting into each individual electrolyte, right? So sodium, we mentioned all electrolytes. What do they do? All of them, what do they do?
Nerve conduction
and muscle contraction typically. Again, what makes sodium so special?
Water.
It's all about water balance. So it kind of works like the kidneys in a way that, it works hand in hand to keeping either getting rid of that fluid or hanging on to that fluid. So, as mentioned, sodium movement is a link between water retention, which water retention becomes blood volume, and blood volume works with blood pressure. We went over that, so it's right there. As mentioned, it's regulated by the kidneys and aldosterone, as we already mentioned too before. If we're too low on our blood pressure, our aldosterone will retain the sodium. If we're too high, then I would imagine we chill out and say, no, we don't need to smoke the out. I would imagine. But sometimes there's weird situations where your body just doesn't work that way. And you retain it or whatever, so on and so forth. And as mentioned, over and over, this keeps being thrusted out there. And what did we learn? When it gets thrusted out a bunch of times, that means it's probably going to come up. So just remember, sodium is a major electrolyte in our extracellular, our blood vessel, our extracellular fluid. So now we can get into hypernatremia, its causes and what the heck could happen, right? So as mentioned, we learned hypernatremia is when it goes over 145 milliequivalents per liter. Typically, some causes for hypernatremia would be situations like where you're not really peeing out as much, which is again when aldosterone's hanging in, right? The same way, high dosage of corticosteroids and estrogens will cause it. Either it could be decreased excretion from ADH, or it could be again from aldosterone's effects of retaining sodium, the same way how ADH does it too. You're not going to be urinating as much out, so you're just holding it all into you. This is going to be a little weird down the line because it could also go the different way too, but it's just like for a different reason, which is a little weird. But long story short, decreased excretion will have you hang on to your sodium the same way how this is just another way these high doses of corticosteroids or estrogens or steroids in general can contribute to decreased excretion. And then the other big one is a major loss of water, like our diabetes insipidus, major trauma, major burns. watery diarrhea, fever, burns, things like that, as mentioned. Too much, like you're sweating. So, but you think, wait, but sodium, like water follows sodium. It could possibly be that these are just situations where you're losing way too much water than you are losing sodium. So, because, like, imagine all this is like your blood vessel, right? And inside is water and sodium and so on and so forth. But we lost all this water. Like, imagine this is our normal. This is over too much, right? Like, I mean,
You're good?
you could just, yeah, you could just kind of picture it, right? So this is our normal, but now we just lost a bunch of water. So what happens? What do we say when like you lose a lot of fluid volume, but the sodium kind of stays the same? It becomes more concentrated. So because that's the vessel is getting smaller, the sodium is getting more concentrated. Which, if it's more concentrated, then you are hypernatremic. So to review, major loss of fluid could be any way. It could be your burns, your fevers, your sweating, which is fevers, diarrhea, excessive vomiting, so on and so forth, where you're just losing too much fluid. The main key term is fluid, because now our sodium is becoming more concentrated. The same way how if you're not urinating too much, you're still retaining a lot of sodium, and it could be by ADH, it could be by corticosteroids or estrogens. And then it's mentioned for a high net water loss, we learned in diabetes insipidus, you're basically urinating water. You're not really urinating like your normal urine. You're just straight water's coming out. So because of that, the sodium stays inside, but the water is coming out. So that makes you hypernatremic. So as for, alrighty, so physiology of hypernatremia. Right? The nice thing is that Jonathan made a really good way to kind of signify our signs and symptoms, right? When we think of sodium and like we're hypernatremic, right? Typically that means we're too salty. What happens when we're too salty? We're dehydrated, right? So when we're dehydrated, we picture a person in the desert, which is what's perfectly shown. Right, so when you're in the desert, we always imagine the person in the desert. They're super, freaking thirsty. They're kind of going a little loopy because they're seeing things because they're out in the desert. They've been out in the sun. So when you're out in the heat, typically feel weak. You and fatigue. So these are both kind of the same thing. Thirst is the biggest one. We've all seen that one meme of the guy like crawling, trying to see for water or whatever. They turn back and they go like for something better. I don't know, whatever the hell. They start seeing mirages. So altered mental status, decreased level of consciousness. You're not really thinking straight. And then as we've always known, when you're super hot or something's really, really, really bad, or you've been completely out of it and you're low on everything, you start having convulsions too. Like, I mean, what happens typically with children running high fevers? Seizures. You're going to be pretty hot. You're going to be very thirsty. You're going to be weak. You're also going to be seeing things, that altered mental status, that confusion, that hallucinations. And then if it's that bad, you start having seizures. The muscle twitching, I mean, that's kind of a blanket thing that happens with everything. Like, you start having failures with everything. Your calciums, your potassiums, your magnesium, you start having twitching. So that's kind of a blanket one for everything. If you kind of want to just throw a blanket over it. But typically, that's what you'll see. This is a perfect representation of hypernatremia because that's exactly what happens. You'll be hot, you'll be thirsty, you'll be weak, you'll be tired, you'll be kind of getting loopy, seeing things, and then finally, you might have a seizure, and then if it's that bad, you die. So, treatment of hypernatremia, right? Pretty straightforward, but there's two different ways to approach this situation. There is hypernatremia by the loss of fluid, right? So you're hypovolemic, right? The biggest solution is you want to use hypotonic fluids because again, the vessels, like we can picture, the grape is all shriveled up. It's a raisin. So in order to plump it up, like you're the raisin in this case, your big body is the raisin, and you're all shriveled up. So the best way to do it is you give a hypotonic fluid, you'll balloon back up into what you're supposed to. So yeah, so if you are hypovolemic, you would give a hypotonic fluid. So that's nice. There's a positive correlation in that way. Now, if you're hypervolemic, right, you have enough fluid, but you have way too much sodium. That's where our thiazide diuretics come in. Because you're hypervolemic, that basically means you have way more than enough fluid. In fact, you might start having edema.
Too much.
Yeah, like too much edema. That's where our thiazide diuretics, which target sodium, will come in. So if you're hypovolemic, you're like super, freaking out of it. Your like blood pressure's low, your sodium is low. Give a hypotonic fluid, and they would probably also give like freaking like sodium supplement as well. If your sodium is super high, and oh wait, no, not your sodium because we're hypernatremic.
Yeah, we're talking about hypernatremia.
Yeah, throw that off. Disregard that one. But again, at least if you're hypovolemic, sodium's too high. Yeah, but I'm overcomplicating it.
Yeah.
Your sodium's too high, but your water's too low. Just bring the water back up. That's it.
You have a rock of salt in your vein. The best way to get rid of it is to pour water into your vein to dilute that rock of salt. Exactly, yeah. So all the salt has turned into a big rock. And our blood vessel's like kind of too small, so it's all concentrated. So if you give fluid, the vessel will grow because the volume will go up, and then it'll dilute it, which is your hypotonic fluid. Yeah, I was making it more complicated than it is. So hypernatremic and you're hypovolemic, so you're low on fluids. Give more fluids, but give the most closest to water fluids in order to just dilute, basically. And then for diuretics, we would give those for people that already have a lot of fluid, like your edema patients, and like to prevent more pulmonary edema. So pretty much, again, just review because I want to make sure not to confuse anybody. Acute hypernatremia for people that are hypovolemic, low fluids. You give a hypotonic fluid. Because again, sodium is up, but water is down. So you want to use a hypotonic, which we mentioned, closest to water, to bring that water back to sodium. So it's all equal. It's all equal now. And then hypervolemic patients, diuretics. Because again, thiazide diuretics help us pee out excess sodium. So I apologize for getting that a little mixed up again. It's just so many hypers and hypos, and you start kind of like mixing everything together. So I did add this as an additional thing for signs and symptoms. You could review that yourself. Now, hyponatremia, right? Typically, this happens when you give way too much hypotonic fluids. Now we're kind of going back to the, reverting back to the slide that was up here. Same thing with our endocrine stuff. If you treat the problem with the solution, sometimes the solution will not make a new problem. Right? You're over administrating meds. So excessive use of hypotonic fluids is one. Also our ADH, because again, initially we're hypertonic because we're not removing a lot of sodium, but now ADH is working a little too well, so now that's causing so much water that sodium, that rock of salt, is now overly diluted because there's too much water. So now we're hyponatremic, and again, hyponatremia, 135 milliequivalents per liter or lower. Beyond that, this is our blanket statement for everything. Vomiting, diarrhea, gastric suction, diuretic use, which again we mentioned before. Using too much thiazide diuretic will cause you to pee out too much sodium, which will make everything lower.
strenuous exercise. This one happens too with potassium and magnesium, if I recall right. So strenuous exercise, that one's like kind of a recurring one. It's not really for. Maybe it's for calcium as well. I don't recall about calcium.
I don't recall.
But at least for potassium and magnesium, for sure potassium. But magnesium, that one, exercise is a big one that you lose it. I mean, after all, what happens when you're like exercising and you're cramping? Oh, I need potassium. Oh, I need sodium. I need magnesium. I haven't really heard calcium that much, but it could be in there. But not as big as like on this one. But so to review, excessive dilution, so hyponatremia by dilution, so too much ADH, too much water volume. These both carry the theme of too much water volume. Whether it's ADH backing up too much water that's causing too much fluid buildup, or hypotonic fluids that are given for an issue where your salt is too high, now you're causing it too low because the water basically over diluted. And then in this one, it's just vomiting, diarrhea, gastric suction. It's your blanket term for the loss of all electrolytes, really. Symptoms of hyponatremia, right? So this one's a little bit more, I mean, it's more salt loss, right? So you're going to be lethargic, always, typically. You're going to, it's possible to have seizures as well. And it says it right here. But I would imagine in excessive. So seizures are seen both in hypernatremic and hyponatremic. But that one's a little bit more extreme. Those are the extremes of both sides. You could have abdominal issues, like a lot of abdominal pain, cramping, and stuff. You might not be that hungry, which is where that anorexia comes. Also, things are low, right? Our sodium is low. What is something that we've learned that is what happens when we're too low? When we're like way too low, where our body's like not really in the. What are some things? Are our reflexes working well?
No,
not really. Usually reflexes kind of drop. Muscles will start twitching, as mentioned before. That one was also part of the other one. Start having tremors, you're getting weak, you're confused. But the biggest one is nausea, vomiting, anorexia, and abdominal cramping, along with the convulsions that come as well. Your respirations might be a little lower, your muscles may spasm. So I added at the end another one of those symptoms as well, but it's a little bit more, this one's a little bit more, it has some elements of the one prior, hypernatremia, but it's a little more.
The abdominal stuff is
the abdominal stuff one is a little bit more unique. But you're not going to be thirsty, the same way how you would be if you're hypernatremic. Oh, actually, we could look at it that way too, right? When you're hypernatremic, you're thirsty, you want to eat, you want to drink and eat because that has fluids. But when you're hyponatremic, your body's like so low that you don't really want to take anything. So, I mean, it's kind of dumb because you would want to take it, but it's like your body's like preventing itself from. Not the best connection, but it's one way to look at it when your body's low. So the treatment of hyponatremia, right? You could typically be giving the fluids that we've always talked about, normal saline, lactated ringers. You could also then change, if they had too much thiazide diuretics, you can now change them to loop diuretics, because loop diuretics typically do cause isotonic diuresis, but you do have to watch out as well, because again, even though it's isotonic, fluid goes in and out easy, you run the risk of also peeing out too much potassium as well. That's the reoccurring theme with our loop diuretics, our furosemide. Potassium always has to be checked. I mean, it's in our skills too.
Yeah.
In our injection skills. What are some of the things that you have to check? You have to check their blood pressure and you have to check their potassium. Pivotal and super important because potassium is so important. Because too much or too little can kill your patient. So this is a risk you run of, but You would typically use a diuretic when there's too much fluid because of the excessive dilution. So where excessive dilution means we're hypervolemic. In this case, what did we give? All the slides up ahead. What do you give when there's too much fluid? You give the diuretic. But obviously, you're not going to give a diuretic that's going to cause too much, too much sodium loss through those thiazines. You would do it with a loop diuretic instead. To just get rid of the water and the potassium in the water, but keep that salt so the salt can kind of balance out by either becoming more concentrated, and then at the same time, you could give, the sodium supplement if needed, or if the hyponatremia was caused because of the sodium loss, you just give them that IV, the normal saline, the lactated ringers. So there's two different ways, well, not really two different ways, it's just two different situations that ask for something different. In mild situations, for all, you just tell them to have drink water. Just drink water. Drink some water. And then, if I recall right, for potassium or magnesium, one of the two, it's also move. I think it was potassium move for one of them, but we'll see it as we go. So again, hyponatremia, low sodium, caused by dilution, you give a diuretic, and ideally a loop diuretic, not a thiazide. For hyponatremia caused by excessive sodium loss, it says cut and dry. Give sodium. Give sodium, give lactated ringers. Give something. Because this one's just straight up sodium loss. This is not sodium loss. This is sodium over dilution. This is dilution. This is genuine loss. Do you really need to get rid of a lot? No, you just need to get rid of the water that's causing the problem. In this one, the direct sodium is causing the problem. So it's two different schools of thought for different, for these two situations. And then as mentioned, I included hyponatremia signs and symptoms. And then this is our big thing. I mean, it's helpful because it covers a lot of different things, but it's like a big giant word salad. Oh my goodness. But it does help. I mean, it's what we talked about earlier. Diabetes insipidus can cause hypernatremia because you're just peeing out straight up water. Excessive H2O loss, again, you're losing way too much water, so the sodium stays up. Low H2O intake, again, you're not making that raisin that is your body back into a plum. So you're just staying all concentrated. It's there. Your low-grade fever, your flushed skin, you're hot, the same desert thing. For hypernatremia, for hyponatremia, it's the lethargy, the headache, the confusion, seizures, coma. Again, so these are kind of like, we already kind of went through those. The other slide had a little bit better about the abdominal pain, the nausea, the vomiting, and stuff like that.
Yeah, it's all linked.
Yeah, so it's kind of linked. This is just a big review that I made. You guys feel free to look at it when you guys want, but it typically just covers everything together. Just to make it quick and easy. So, okay, potassium balance now. All right, so potassium, super most important intracellular fluid. Well, no, sorry, not fluid. Intracellular solute ion, whichever one, they're both used in nutrition. So, this is the most important one because, again, it has a lot to do with nerve and muscle function. And it also has a lot to do with our acid-base balance. We lose too much potassium, we run the risk of becoming alkalotic. We have way too much potassium, we run the risk of being acidotic. But typically, it doesn't really work that way. It's more the loss of bicarb that causes us to become acidotic than it is losing potassium. But again, different situations, different possibilities. It's just more to get your mind.
Based on the question you get.
Yeah, it just really depends on the question. It's influenced by aldosterone, and I put right here a little chart just to be a quick review, because if we recall right, high levels of aldosterone will cause high levels of sodium, but when we're in the kidney, and the kidney is like, hey, I gotta excrete something, and aldosterone is the influence in this situation. I have sodium on my right hand, and I have potassium on my left hand. Aldosterone is going to be like, nah, let's keep what's in the right. So we're going to have to get rid of this. What is this? This is potassium. So when there's high levels, your Cushing syndrome, aldosterone, high levels of aldosterone with Cushing syndrome, it will cause us to have high levels of sodium. What did we learn? High levels of sodium with Cushing syndrome, high blood pressure, high fluid resorption. So again, this is why it's influenced by aldosterone, because now what if we flip it? What if we have Addison's disease and don't really have a mineralocorticoid going on? Then now our sodium is super low because we could urinate it out a lot, and our potassium is super high. So it's just a quick little review. Low levels of aldosterone, which is adrenal insufficiency, will have low levels of sodium while having high levels of potassium. High levels of aldosterone, Cushing syndrome, will cause high levels of sodium and low levels of potassium. Quick little review, because maybe you forgot it in all this time, just to give you like something, oh my gosh, what do they mean by that? There it is. And then this is the biggest part. This is like the most important thing. Most of those YouTube videos with all the nurses, like, teaching their knowledge, this is the most important thing. They can be fatal because they cause cardiac dysrhythmias. They can cause your T waves to spike or become U waves, or like, inverted T waves or whatever the heck. But very dangerous. So, quick review: nerve and muscle conduction, acid-base balance, influenced by aldosterone. So keep that in mind. And then it could be fatal because heavy loss can lead to that.
The acid and heart stuff is very specific to potassium.
It is.
Right? The sodium is the water.
Sodium is all about water. Potassium is all about
acid and your heart.
Acid in your heart. And it's influenced by aldosterone.
Yeah.
Then you could even say for the sodium one too, because it is influenced by aldosterone too. So potassium and sodium, they're both kind of like the yin and yang. Mm-hmm. They're both influenced by aldosterone in two different ways, but they're not. Potassium has a uniqueness about being about acid-base balance, while sodium has a uniqueness of being about water control, or fluid, not water. It's not just water. But, hyperkalemia, right? So usual causes is you eat too much potassium-rich foods, bananas, potatoes, spinach, kale. Or you have chronic kidney disease, CKD. Or you use way too much of that potassium-sparing diuretic. It's pretty much that. There's also other indicators, there's different other ones too, but these are the ones that were at least displayed to us. Mm-hmm. So very important to know that. Because, it makes sense. Again, potassium-sparing diuretics, you want to be careful with this. So always check your potassium, because the level might be already high. Eating too much food, this is a blanket statement for all, if you think about it, right? Because if you eat very salty foods, run the risk of being hypernatremic. Or you eat foods with a lot of calcium, hypercalcemia, and all those different things. So there's so many, again, this is just a blanket statement, but the most unique, the most to this only, is that potassium-sparing diuretics
and the CKD
and the renal disease, which is the CKD. And then, as mentioned before, 5 equivalents per liter or higher.
Your dialysis patients.
Pretty much. So, symptoms of hyperkalemia. The biggest one is going to be the dysrhythmia and the heart block. And that's the biggest one, because it's mentioned. So there's two trains of thought. That heart block could end up becoming a full arrest, a cardiac arrest. But before that, it would be a heart block, right? And the way we picture it is because we know our EKG movements, right? So when you're having a dysrhythmia, you're having issues with that. A big thing that would happen when you have these heart blocks and stuff is that your heart can't really, it's going to try not to skip beats as it's going. Because if there's heart blocks, which we'll probably learn later down the line. Heart blocks cause delays in cardiac conductivity. You can't really have a super high heart rate. That's why you would be bradycardic in a heart block, because your beat goes with the ventricular contraction.
That QRS.
Typically, your heart blocks affect the P to Q interval, which again, it's a little bit more ahead, but if we recall from physio, that's what heart blocks directly affect. And what did we learn too in Tamayo's? Ventricular contraction is basically the representation. Well, it is basically pulse, which is the representation of pulse. And we can't have a pulse if there's a delay. So your body can't be like, all right, I'm already in the race, if the race hasn't even started because the message is being conveyed. So this is why we would have dysrhythmias and we would have a heart block. And then the biggest thing is the bradycardia, because you can't skip steps. Mm-hmm. It's like when they say, how do you make a sandwich? You can't be like, okay, well, we get the bread. Well, how do you get the bread? And it's like, all right, where are we actually starting? So you have to think of it in a segment in that way. Same thing, muscle twitching, fatigue, paresthesias, dyspnea, cramping, and diarrhea. These are kind of symptoms you kind of feel in all of them, but the most unique one is the dysrhythmias, the heart block, the bradycardia. It makes sense to have the muscle twitching because, again, what happens when you work out too hard? It's the same way you lose potassium, right? And this is hyperkalemia. But again, potassium, we'll notice that a lot of these hyper and hypo, whether it's sodium, potassium, calcium, or all that, they kind of have similar side effects or signs and symptoms. Mm-hmm. They have very unique ones to themselves too, but typically they'll have like similarities. Like with hypernatremia, with the sodium one, we saw that they both have seizures, whether it's low or high, doesn't matter. They'll both have seizures. Yeah. These hyperkalemia and hypokalemias we're about to see, they both have dysrhythmias. It's just going to be like, which one is it going to be first? So it's kind of, the best way I could think about it is just focus on what makes them super unique. Obviously, if you could get all of them down, that's even perfect.
Great.
Right? Yeah. But it's a lot of information to pack into your head. At bare minimum, just get the most important ones, which is those dysarrhythmias, those different things.
Even that paresthesia is kind of unique. You will see that somewhere else, but that's that numbness, that pins and needles feeling.
Loss of feeling or abnormal feeling and things like that. So again, there are typical things. We'll see that with hyperkalemia. You typically use the anagram murder, which is going to be on the slides down the line. But again, they'll at bare minimum get the dysrhythmias, but the muscle twitching, the fatigue, again, these are kind of indicative of
everything, right? Yeah. We get what you're saying.
Paresthesias. You can put dyspnea, like painful breathing, because you can have chest pain, which is caused by the heart block, so you make that connection. But then in that case, you would also have dyspnea and low potassium too. So, bare minimum, just be aware that there are little differences. So as for treatment of hyperkalemia, right? We restrict dietary resources like you do with everything. So that's a blanket statement. You decrease the dosage of potassium-sparing diuretics, which makes sense. If you have a big problem, so you don't want to cut down the treatment over it. We talked about this too, administering glucose and insulin. We talked about this earlier. Because insulin helps potassium go into the cell, thus it goes down in the serum. And then we mentioned this already too, polystyrene sulfonate, or K-exalate, which sounds like excrement, K, potassium, exalate, excrement, and sorbitol, which I would imagine does the same thing. I would look it up, but I would imagine it does the same thing. I would just make a weird connection to that, like, I don't know, sugar ice cream, sorbet ice cream. Like sorbet ice cream, you got diarrhea from it, so you put time. I don't know. And then again, in mild cases, this is that one, increased mobility. Yeah, have the patient just drink water and move. Because if you have too much potassium, you want to move your body to use up that potassium. You also want to drink water to dilute that too much potassium too. So those are kind of some angles. There's like a lot of different ways to address it. Best thing to do is recognize them. And okay, cool. So sorbitol does exactly the same thing as K-exolate. So recognize the sorbitol and K-exolate, or sulfonate, or polystyrene sulfonate. Sorry about that. So just recognize these two, but also the brand name, because that could also come up in the test. But the biggest thing is our restrict sources, decrease dosage of potassium-sparing diuretics, give glucose and insulin, because you don't want to just drop their glucose as well with the insulin. You give calcium to counteract potassium toxicity. It's the same way how we saw with patients that have too much levothyroxine. You give them a beta blocker, because the levothyroxine can cause damage to the heart and overdoses. So it's the same way as that one, but in this case, you're giving calcium for that potassium toxicity to the heart. And then again, polystyrene sulfonate and sorbitol, and then you educate your patients to just drink more water and move. If they have too much potassium, move. So they use it, then they can pee it out. And then, here's that mnemonic, the murder that came in. So muscle weakness, again, that's kind of standard with everything. Urinary output is going to be little to none. So I would imagine that's because you're what do you call it? You're not urinating as much, right? And you're retaining that, especially if you have the whole. That's kind of the weird thing. Like a lot of these different sources, they have so many different they kind of butt heads with some things that are in our book, but they say it's that. So this one, you could take it kind of with like grain of salt.
I would think that relates more to your CKD patients because they can't excrete it.
Oh yeah. Oh, actually, no, that perfect. That's even better. Yeah, this is more indicative of sign. I was thinking more like because you think this is like signs and symptoms, but this is more cause, not really.
Oh, okay.
Yeah, that's why I was like trying to make how's this a sign and symptom? Because you want to urinate, but yeah.
And
again, it's
like get it out, it builds up, right?
Yeah, I'll add a little note here that CKD, because it's true. That's exactly right. We just talked about it. CKD, the respiratory failure. I mean, when you have high levels of stuff, your body gets so overwhelmed. But also when you have low levels of stuff, your body just poops out. So it's again, you're overwhelmed, you go into respiratory failure. Your body poops out because you're too low. You could also go into respiratory failure. It happens to so many of these different things. They're all signs and symptoms that all kind of they either happen in both situations or they kind of butt heads. The decreased cardiac contractibility, that's our lower heart rate, that's our bradycardia. And then our early muscle twitches, again, because there's just a throw off of what's going on. Like things are unleveled, you start having the spasms and twitches that we were talking about up here. And then rhythm changes. Or tall T waves and prolonged PR interval. The biggest one is that T wave spiking up that I don't really think we'd get like a picture of it, but at least it gives you an idea. So hypokalemia, right? We have potassium levels that are lower than 3.5 milliequivalents per liter. So usually it's that overuse of loop diuretics, as mentioned. Overuse of it can cause high potassium glycemia. Strenuous muscle activity, which is, again, kind of all of these, but big on magnesium, if I recall right, calcium, and also potassium. And then severe vomiting or diarrhea. Again, these two are just everything. They're everything. We talked about it all the way up there. All our ways to lose fluid. Over sweating, over loss of GI stuff, whether it's vomiting, whether it's through vomit or diarrhea, or through blood or burns and stuff like that. So kind of
focus on that.
It's more unique. This is big. This loop diuretic, this is big. But still.
Yeah. What did you call it? Furosemide?
Furosemide.
Furosemide and the trade Lasix, right?
Lasix.
Lasix. Yeah, that's going to be big.
So this is the big one.
Yeah.
But I mean, still kind of pay attention to these. It's just keep in mind that this is the most like, oh my goodness, that's the big thing. But I guess don't get tunnel vision too. Know that heavy muscle activity, because again, it's like, what do those drinks have? Those electrolyte drinks. There's like one of them out there, and it's like has like, oh, we have potassium and magnesium and calcium. So that's how I remember, heavy muscle activity. I remember that drink, and it has like your ions. That like it's just an informative like oh look, it has this, so your body can work correctly because you worked out too hard. And then your severe volume that always happens. So again, your symptoms of hypokalemia, right? So just the same way how neurons and muscle fibers are very reactive to having high levels, they also have it to low levels as well. Same thing, muscle weakness. It's weird. We have that also up there, but for hyper. Lethargy. It's kind of another way of going with muscle weakness. Anorexia. Where did we see anorexia?
Sodium.
Low sodium. Low potassium. Low potassium. Also seen in low sodium. So it seems like we're seeing a pattern. When you're low on these situations, it seems like you just don't want to really eat. Seems like it, because it keeps reoccurring. Dysrhythmias is our big one, and then cardiac arrest. You could also be tachycardic. So this is where that whole, like the yin and yang, right? They both have dysrhythmias. However, hyperkalemia will have bradycardia, while hypokalemia will have tachycardia. So you kind of have to recognize that there are, again, those similarities, but there's also differences.
You know what? To go back one slide, we kind of glossed over the diet. You know what? We shouldn't actually do that because especially the vomiting diarrhea is going to be big in metabolic alkalosis.
Oh yeah, that's right.
So you shouldn't gloss over that, right? Mm-hmm. Or like whoever's watching this, you shouldn't gloss over that.
Yeah,
that's gonna come up later.
Oh, that's right. Mm-hmm. That's true. Well, I mean, in terms of the vomiting too, our stomach acid does have a lot of hydrogen, but it also has a lot of potassium too. So again, alkalosis. That's a big one too.
Yeah.
That severe loss, especially with this being potassium. So again, the strenuous muscle activity, that's kind of universal. But the severe vomiting or diarrhea, and then the high dosage of the diuretics. Those are the big ones. Yeah. But it is true that's a good catch. Because it does come up.
It's going to come up.
Like basically at the end. Like it's like the last couple slides. But yeah. So blanket statement, kind of universal, but these are very important. All right.
Sorry.
No. Perfect. Catch whatever I miss, because that's important.
All
right. So
I think we all missed it.
I know. I mean, like you just go automatic, so it's like so much stuff. So as mentioned, so you do have to just recognize that there are differences. There's similarities. The weakness, the lethargy, that was in both. The anorexia, again, we can note the pattern with hyponatremia and hypokalemia that you don't really want to eat. So that's like you can kind of form patterns in your head. And then dysrhythmias, cardiac arrest, and your tachycardia. So at least those like form the pattern a little bit, and you get treatment of hypokalemia. Increase dietary intake. It's that simple. If it's that bad, you could give that giant horse pill, or you can give the potassium chloride IV through. But you don't give it through IV push, you give it through a peripheral line. I shouldn't have said it, just you give by IV, because that sounds like a push. So the biggest thing is that because an IV push of potassium is a lethal injection. So that is very, very major. And especially how you're pushing it all in like one go, like even if you're going slow, that's a lot. So you typically want to use a peripheral line, or you could also have a central line. A peripheral line will have 10 milliequivalents per liter, and a central line will have 20 milliequivalents per liter. And again, there will be a pump that you will like use on it, and it's being very precise how much because you don't want to overload the patient with potassium because that can kill them. Well, like we learned with hyperkalemia, you could kill them. So again, it's not just IV push, but it's genuine, like just your line with your pump, your patient's getting it, and they're only getting 10 milliequivalents. That's super low.
It's not a single state. It's a pump.
You use a pump. You have to use a pump. Yeah.
Exactly.
Yeah.
And that's really low per hour. 10 milliequivalents. That's legit. Just like that's low because that's what you want. You don't want to overload them because you're gonna overwhelm them and then you're gonna kill them.
It all goes back to the heart.
Exactly. So that's why, big thing. And then for this one, we have the 7 L's. Yeah, so the 7 L's of low potassium. So it's our lethargy, which was mentioned already. Low shallow respirations. You see how this one was also low shallow respirations and respiratory depression was on the hyperkalemia. They both showed up. So again, it's like they both present with these symptoms, but this one is more because your body's giving up, while in the other one, your body is overwhelmed and it just gives up. Like this one's you give up. The other one is like your body tried and then it gave up. So just note that they're both the same thing going on. Lethal cardiac dysrhythmias. Lots of urine. So look at that one.
Opposite.
You see, opposite. So in the other one, you don't pee anything out because the CKD is causing the urination issue, which is the perfect thing that you caught.
That's the best thing.
But in this one, it's lots of urine because lots of urine is causing. Again, that's why this is more the cause. Like yes, it's a symptom, lots of urine, but this is like a cause of it. That's what was like kind of confusing me up ahead because it's like, wait, so it's like I'm trying to see the pattern.
Yeah.
But you caught it perfectly with that chronic kidney disease stuff.
Unless
the
there's
leg
something
cramps.
else, think of something else. I don't know something else.
The leg cramps. Yeah. The leg cramps. I mean,
everything cramps.
Yeah, like
it's weird. It's weird.
And then limp muscles. That's just again part of lethargy again. Here's the interesting thing. Low BP and low heart.
Didn't we just say tacky?
So that's the interesting thing. Professor Huang said you become tachycardic. But this, from the lady registered nurse RN, she has it as low BP and heart. You see, the interesting thing is that a lot of different places kind of say
different shit.
Different stuff. So it's like, I'm going to go with what Professor Huang said. But I mean, it wouldn't be out of the realm of possibility to have. Like maybe it could be that, because you're having low potassium, your heart's kind of going into shock. And what happens when you go into shock? You become tachycardic. But then eventually, once you're starting to go down the drain, then you start having a low blood pressure and a low heart rate.
So a later symptom maybe?
Again, so it's like you're kind of putting in puzzles or like trying to rationalize it. So it's not perfect. I mean, it's so much stuff to remember that it's like a little hard to pinpoint.
I would stick with the tacky. Right?
Yeah, I would stick with the tachycardic too. But I mean, again, it's not out of the realm of possibility. So
the prolonged PR in the hypo, right? The prolonged PR in the hyper, right, would make you bradycardic.
Yeah,
that makes complete sense. So if you have too much potassium, if you have a shortened PR, making you tachycardic, I would think.
Yeah.
Right. Which makes sense.
Yeah.
And then you would have low BP.
Once
you're taking,
you have a shorter PQ interval that could allow you to have a like a higher heart rate. So
right.
yeah, this is another word salad. It's a lot. Like, it's like, oh my goodness. But big things to know: ACE inhibitors and NSAIDs, those can bump up your potassium. So right now we'll just focus on high levels of potassium. Acidosis, metabolic and respiratory. Again, you could lose a lot of bicarb. And then now, like, here's your bicarb, here's your potassium. If you lose this, what does this look like now? Hyperkalemia. Just because of the distro, the throw off of levels or whatever the heck. Cellular destruction. This one is big. Burns and traumatic injuries, and the biggest one is rhabdomyolysis. Registered nurse RN was talking about that. What is rhabdomyolysis exactly? Do you guys know?
Where your muscle cells destroy them, like they get destroyed, and whatever's inside comes out.
And what did we say is inside the cells?
Potassium.
So high. Now you're having it in the serum, which is causing your potassium to go up. So again, it's like now we're forming patterns, which is perfect. Excessive intake of fluids, that's everything. Nephrons, renal failure, that's CKD. Again, you're not going to be urinating, so you're not going to go ahead and get rid of all that potassium, which backs up and then causes toxicity, otherwise known as acidity, and hyperkalemia. And then excretion impaired, these are just legit kind of
the same thing,
right? Here's the muscle twitches, your cramps, your paresthesias, which also happens over here too. And irritability and anxiety. I mean, this one kind of happens a lot with hypers, but also hypos. You're irritable and you don't feel good. Yeah, you're not feeling good. Like, I mean, that's kind of straight up. This one has your low BP. For high levels of potassium, it has your low BP. I mean, we did talk about it. We have also a low heart rate because of heart blocks that occur first. Dysrhythmias, irregular rhythms, abdominal cramping, that pain, which kind of happens with kind of everything. The diarrhea as well. But the funny thing is, again, diarrhea will cause a loss of potassium too. So it's like, oh my goodness, there's so many things going on at once, and it's kind of hard to gauge.
Yep.
But potassium deficits, that means low potassium, your osmosis, you're having shallow respirations, your confusion, drowsiness, and weakness, fatigue. It's also happening over there. Your lethargy, which is legit weakness and fatigue too. Your arrhythmias. And here it is, tachycardia right there. Oh, for hypokalemia. There it is, tachycardia. So again, depending on your sources, it might be a little different, but there it is, right there. 30 pulse, it's going to be weak, obviously, because you're not having enough potassium that's helping you contract that more. And then this is just a quick little review. Again, big emphasis for hypokalemia to not give them by IV pushes. We'll freaking kill them like that. But again, just a quick review. I mean, look, dysrhythmias, heart blocks, dysrhythmia, cardiac arrest. But in this one, I should add, actually, I'm gonna add the bradycardia on this one, and I'm gonna add tachycardia is already on that one, so we're good on that. But remember, hypokalemia, hyponatremia, anorexia, because we don't want to eat that much in both situations. But in this one, again, there's a twitching that happens that's more unique on this. There's a diarrhea. So, it's kind of there. But usually then we have our treatments, on both ends. And for the hyperkalemia, you have lower the diuretic use, potassium-sparing diuretics, restrict diet, insulin admin. So it's just a quick review of everything that we've done. And then now we kind of go into hypercalcemia and hypocalcemia. There weren't really any slides on this, but I kind of just made a quick little review thing. We have talked about this before with our calcium in our past two exams.
Chapter 48.
Yeah, like they were both in this. So, there's way more causes. Like, there's way more. But these are just a couple. Because, again, it just keeps your mind moving a little bit. But we remember that with hypercalcemia, we can use the anagram weak. You typically have your weakness. You have high levels of urination typically because you're trying to pee it out. You could have dysrhythmias as well because of heart. What did we learn in physio? Calcium is super important for heart contractility. Well, muscle contractility in general. Our heart is a muscle. You will be dehydrated. So this is where what's interesting. In hypercalcemia, kind of has somewhat similar signs and symptoms as like those first few symptoms of hypernatremia. The thirst and the dehydration kind of there. Thirst is a little bit in the air, but dehydration is there, which is what happens with hypernatremia. Kidney stones is a big one. I mean, after all, it's called renal calculi. So what is renal calculi? It's legit kidney stones because of an accumulation of typically calcium that collects in the kidneys, and then now we're peeing out rocks, and that doesn't sound fun. And then we talked about it too. What are some treatments? Calcitonin, hypotonic fluid. Either pee it out, put it in the bones, or dilute it. It's really
simple as that.
Yeah. Hypocalcemia, right? So we have our causes. So low intake, low vitamin D. It's there. Low PTH, because what did PTH do? What does it do? It increases it by bringing it out of the bones, and then diarrhea as well. I mean, diarrhea is a cause too for which one was it again? It was one of the potassium ones.
Hyponatremia, is that what you're talking about?
No. Oh, diarrhea was also a cause for hyperkalemia. Oh, wait, no.
I would think. We would have to go back.
Yeah, we could just go back over. It was hypo. It was hypo.
Yeah, right. Because we were talking about metabolic alkalosis.
Yeah. So yeah, there it is. I mean, this is more review. I mean, what the biggest thing too that's very nice about learning about hyperkalemia, or I'm sorry, hypokalemia, is that a lot of it has to do with conductivity issues, spasms, twitching, seizure, tremors. Those are our big ones. Reduced muscle reflexes, because can you really have a reflex if you're constantly contracted? Because that's what calcium is doing. It's contracting you. Can you really have like a good reflex? No, because your your reflexes go down, which is what we have. Reflexes.
Perfect. And you've got those Trousseau and Chekhov signs down there too?
Yeah, Trousseau and Chekhov. So this is what's interesting. Reflex is hyperactive. This one was pointing to convulsion. So this one, again, weird kind of ways to go about it, because there's different sources. This one says your reflexes are up. But if I recall right, the book said that our reflexes are kind of down because we're too contracted. So it's like, which is it? I'm not too sure. So that one's a little weird. But as long as you know your twitching, cramp, spasms, and seizures, that one's a big one.
These would be hyperactive, right?
Yeah,
and then your convulsion.
I was just thinking because of
where you're super.
I was thinking more reflexes, like this. I was thinking more.
You know what? You're right. Yeah, you're right.
But that one's a little bit gray, honestly. Yeah, that one's a little bit gray. Honestly, if you could find out a good way to remember it, I'm all for it.
Yeah, we could.
Yeah.
We could look at the book after this.
Arrhythmias was there. I mean, prolonged QT intervals. So again, arrhythmias affect both. They both cause arrhythmias. So we learned with potassium and we learned with calcium, they both cause dysrhythmias. The muscle spasms, we already talked about it. Now, as for Trousseau's is when you give a blood pressure to somebody and the blood pressure is rising over their systolic, right? As it's supposed to. And when that happens, if they have low levels of potassium, they would typically, their hand would start, their thumb could flex inward, but the fingers will stay straight. And they'll do this. And they'll stay kind of like this with the blood pressure cuff on as it happens. So that's a big one. Another thing too with how do you say
Chavostic?
Yeah, Shavastic sign. So Shavastic sign is if you were to tap the cheek. You know how I'm not really like making any faces right now if I'm tapping the cheek? Typically, for somebody with low levels of calcium, if you tap their cheek, their face can start doing this. Like they'll start twitching more. And that actually goes hand in hand with the reflex is hyperactive. So you know what? That kind of answered it right there.
There you go.
Yeah, that kind of answered it right there. If you're doing that and your body, there you go. There's one way to remember it. We just did it right now while yeah. And then paresthesias as well, because I mean, yeah, that kind of happens with all of them. So there's that. There we go. It's a good way to remember it. And then again, what's our treatment? Give vitamin D with calcium supplements. And if it's really that bad and it really needs it, you give calcium vitamin.
Yeah. All the calcium stuff is on chapter 48. Like
pretty much, yeah. Like it's like the father chapter, and then everything else is like its offspring, or mother chapter, or whatever. So now we have magnesemia or magnesium. The nice thing is that magnesium is talked about later in the vitamins chapter, or vitamins and minerals, but we'll get to that in the coming days. So in this one, 2.1 or higher, 1.4 milliequivalents or lower. I don't know. My way of remembering is like the 21 kid.
Oh yeah.
Yeah. But I think like instead of 9 plus 10, it's like what's 1 plus 4? And the kid says 21. I don't know. It's just one way to remember it. Because it's just like, it's such a weird like set of numbers. You're like, how can I make the connection? It's like, I don't know. What's 1 plus 9?
Yeah.
21. And then you just put a decimal in 21. Stupid.
Are those your numbers or are those the book's numbers?
No, these are the
books numbers.
Yeah,
okay.
these are the books numbers.
Yeah. Just so people know what they're looking at.
Yeah. If I recall right, these are the books numbers because I wrote them down from when I did the research on the freaking graph. So biggest thing to know about magnesium is that magnesium is just like all the other electrolytes, super important for muscle conductivity, along with other things. Very important for other things. If I recall right, has like other things in regards to like. Actually, let's not get into that because that's getting kind of really complicated. The biggest thing to know about magnesium is that magnesium is an ion that is used to relax the body. So it's kind of like the direct opposite of calcium. One of the biggest things to note, though, is that calcium levels and magnesium levels will usually coincide together. If calcium is low, your magnesium will very likely be low, and vice versa. If your calcium is high, your calcium will very likely be high. So, big thing to know. The nice thing, and then it's very straightforward on the causes. The causes of hypermagnesemia, that doesn't usually happen, but a lot of times it does happen when you're trying to fix hypomagnesemia. Or, sometimes it could be happening because one thing I just remembered right now, magnesium is given to pregnant women with preeclampsia to lower or treat seizures caused by preeclampsia. So again, there it is. You're relaxing a seizure. What is a seizure? An overexcitement of the body. And you're using magnesium. There it is. It's proof that magnesium calms the body down. So, CKD, the same way how potassium, if we have CKD, we can't get rid of potassium, then you can't get rid of magnesium either. So again, there would be a loss of urine, just like how we saw in potassium. And then high antacid use, because I guess antacids not only come a lot with bicarbonate, but I guess magnesium as well. And I guess that could be seen in a way because again, it's more like a relaxer. Maybe make a connection.
Makes sense.
I mean, it's acidotic. When I think of acid, like in my mind, I think of like something acting crazy and volatile. What do you want to do to it? Relax it. So magnesium, so maybe overuse of antacids. I don't know. That's kind of a way to picture it. But here's a big thing. right? Magnesemia, we learn hypermagnesemia, we learn that the body is relaxed. So what happens if you have way too much magnesium? Your body is going to relax way too much. Now, this is a big, like, signs and symptoms thing to remember. The biggest thing to know is that your body's going to be really relaxed, which is, and you're going to be weak, lethargic, like super down, because that's the whole point. You're going to be thirsty the same way, again, like how we saw with hyper, I'm sorry, hypernatremia. Sorry, I was going to say calcemia, but that was more dehydration. You're going to be confused, but the biggest ones, you're going to have a low blood pressure. Because if you have high levels of magnesium, your heart's relaxing too much. What happens when your heart relaxes too much? Your blood pressure goes down. Respiratory depression, it's going to go down too, because you're now way too relaxed. And weakness, because that goes on. Same thing, EKG changes happen with this one too. It's prevalent. There's a hypotension. Tendon reflexes are absent or diminished because, again, our body's too relaxed. Arrhythmias can happen. Same thing. I mean, again, it's happening with potassium, calcium as well. Red hot face. Okay, there it is. There's that connection with natremia, with hypernatremia. The flushed skin, the excessive thirst, the like kind of hot feeling. There it is with magnesium too. GI issues, which honestly kind of happens with everything. And then impaired breathing. There's that respiratory depression, confusion again, because you're so down. When you feel so down, like, are you really there? Are you making the best choices? No. Now, as for hypomagnesemia, so we just learned that we have too much magnesium, which is relaxing the body. What happens when we don't have enough? Now our body's too excited, right? Now we have, like we saw in our low levels of calcium, we have hyper-reactive reflexes like Trousseau's and Chvostek's sign. What we saw with having hypocalcemia. Because now our body's too excited. We have our weakness, which is, again, universal. We have increased deep tendon reflex, which is part of that whole, your body's more excited. And then you have this other thing called Torsades de Pointe, but that's EKG stuff that they're going to die if they don't get any help. This is bad. This is really bad. They also have tetany. Tetany, they're like super contracted because, again, they're too excited. And then calcium and potassium levels are low. Again, low levels of magnesium usually are indicative of low levels of potassium and calcium. And then hypertension, because again, our body's so excited. So there it is.
Sweet.
Now we can get to almost the final part. And this is thankfully the more simpler of all of them, kind of. Alkalosis and acidosis. Pretty straightforward. We learned that in physiology, we have our ranges of 7.35 to 7.45. Thank the Lord, we just know that like the back of our hand. Biggest thing that we also have learned in physio is that the kidneys and the lungs work as a balance to those different pH level discrepancies. Our lungs can work by blowing out CO2 more and increasing our breathing to bring in more oxygen, which helps us make more bicarbonate, and along with oxygen helping us become more alkalonic. Or if we're too alkalonic, now our body's going to relax our breathing, become shallow and slowed, and increase more CO2 in the body. So one, we're not losing it, and two, we're making more. And then for kidneys, what does our kidneys typically do? What ion do they like? What's our urine's pH typically?
Oof, I don't know.
I mean, it's not straight up like we're not peeing acid, but it's a little lower than the 7. It's like 5 to 7 if I recall right. So our P typically has a lot of hydrogen ions, typically. If we are to be acidotic, our kidneys will try to urinate more hydrogen ions, more potassium ions, and then vice versa. Now, if we're acidotic, if we're alkaline, right? Our body, I mean, that kind of goes hand in hand. But the thing is, like, bicarb can be reabsorbed or it can be removed. But, if we're alkalotic, we can pee out bicarb. That's what I was trying to get to. Mm-hmm. It's possible to do that. And then both symptoms have an underlying disorder, which again is mentioned. The interesting thing to know is that acidosis will cause CNS depression, while alkalosis will cause CNS stimulation. So the big things to remember. So acid, think body's going down. Alkalosis, think the body's being hyper excited. And then we have two different ways. Again, metabolic, and we have respiratory origins to our acidosis or alkalosis, right? So we've learned with respiratory acidosis, typically it could be from choking, because you have something lodged in your throat, you're not getting air through very well. And because you're not getting air in or out that well, you're having a buildup of what? CO2, yeah, carbon dioxide. So now, all that carbon dioxide we learned is acidotic. So that's causing acidosis. CNS depression, destruction of the medulla, or alteration of the medulla, same thing. CNS depression used by opiate drug use. We're freaking low and we're going to have low respirations, CO2 buildup, acidosis, or heavy damage to the brainstem. We've seen it. It's seen before in major trauma. They just completely go out with their breathing, and then hypoventilation will be a sign of damage to the respiratory center. I mean, that's what happens exactly. Whether it's alteration of the respiratory center or damage to it, you'll have hypoventilation and shallow breathing. As for respiratory origins of alkalosis, right? What's some ways? Asthma, or typically any breathing issues that's making you breathe too much and taking too much oxygen. Now you're having too much O2 and you're blowing off that level of CO2. We learned in physiology that there is a certain level in our ABGs, there's a certain level of CO2 in our blood. And typically it's from 35 to 45 milliliters of mercury, if I recall right, by partial pressure of CO2. That's what we need. And usually we want to be in that 40 mark. We want to be right in the middle. We don't want to be too high. We want to be too low. We want to be right there. When you breathe in too much oxygen, your levels are getting thrown off. So you're breathing too much oxygen and your CO2 is starting to go like this. And now we have too much O2. So now we're alkalotic because our CO2 got shrunk. It got shrunk down. It got diluted, I guess you want to call it that. The same way how anxiety, panic attacks will make you hyperventilate. And then just being in high altitudes. I mean, it's harder to breathe. What happens when it's harder to breathe? You try to breathe more. It's what's happening in anxiety. People think they're not getting enough oxygen, so they start breathing more. It's the same way it's harder to breathe in high altitudes. But in high altitudes, oxygen is more. I mean, it's more constant, because it's out. So you take in more as you're breathing in more, so now you're blowing off that CO2 again. You're causing that abnormality that you're forking off on the road. Same way, how there's metabolic acidosis, now we have severe diarrhea, which we established our stool is typically alkalotic. Just a little bit. It's a little bit alkaline. So if you lose a lot of stool, a lot of poop, a lot of whatever the heck you want to call it, what did we learn? When you lose too much acids or bases, when you lose too much bases, what are you susceptible to? Acidosis. And then in complete mirror, or not mirror, but like complete inverse. Metabolic alkalosis, being constipated for too long. You have a buildup of that alkaline stool in your colon. Now you have too much alcohol. Now you're becoming alkalosis. Kidney failure. You can't get rid of waste. That one's pretty straightforward. If you can't get rid of waste, if you can't get rid of urine, which is what has a lot of hydrogen ions, what are you susceptible to? Acidosis. Diabetes mellitus or mellitus or whatever the heck. Ketoacidosis.
Mm-hmm.
I thought it was right here. Never mind. Ketoacidosis or hyperosmolar hyperglycemic state. I know hyperosmolar hyperglycemic state doesn't exactly go straight into acidosis, but you do create a buildup of lactic acid because your body's not using sugar to produce energy. What did we learn? When there's no real way to do it, you kind of start doing anaerobic metabolism, and that basically creates like a bunch of lactic acid for like 1 or 2 pieces of energy of ATP. In comparison to glucose that makes like 20 to 25. So again, it's like a little bit more steps, but long story short, at least remember DKA, because DKA will cause acidosis. Hyperglycemic state, but there are things that can contribute to that as well. Excess alcohol ingestion, what I'm having a hard time making a connection to, but
I don't know.
I guess you just have to remember that. And starvation, this one is going to cause you to eat up your lipids, your ketones. You're going to make ketones. It's also going to cause you to eat up your proteins, your muscles. If you have no carbohydrates, your body will use up lipids first. And if that doesn't work, it'll eat up your muscles. And all of that creates acids, lactic acid, which will cause you to have acidosis. As mentioned already, metabolic alkalosis, constipation, because that stool's collecting up in there. So now we're having that issue. Ingestion of excess bicarb, right? Tums, too much Tums, too much antacids. Diuretics that cause potassium depletion. This is where it came up, where you caught it. And severe vomiting too. All that vomiting of potassium, hydrogen ions, sodium ions, all right here. I only put potassium because potassium has been the biggest theme of it being an acid, an acidic, an ion. But in the end, it's still hydrogen, sodium, and all that stuff. But yes, severe vomiting will cause you to lose all those acids in your stomach and make you alkalotic. And then diuretics again. You're losing your loop diuretics, your furosemide, your Lasix. And then this is just showing off the balance and the solution. If you're acidotic, too much acid, your body is going into CNS depression. The solution is give sodium bicarb. There it is, because it's alkaline. And then in the other way, you're alkalotic. You're in CNS stimulation. You could have seizures because that's like the epitome of CNS stimulation. Then you would give, in really bad situations, ammonium chloride, if it's that bad, or sodium chloride with potassium chloride suspended in it. So in mild situations, sodium chloride with potassium chloride. In really bad situations, ammonium chloride. This is the emergency one. This is the one where it's like, they're not really there yet. This one is they're probably there yet. They're probably. This is just a review of what we went over. And this is legit just talking about the signs and symptoms. Lethargy, for acidosis, we talked about this. You're going to be down, you're going to be tired, you're going to be lethargic, you're going to be confused, you could go into a coma, because what did we say that acidosis is to the central nervous system? It's a depressant. You're going to have deep, rapid respirations. These are Kussmaul respirations because you're acidotic. Your acid in this spectrum is like right here. In this spectrum that you see right here, it's right here, when it should be right here in the middle. So you're over here. If you breathe more, you're going to even it out a little bit, which is what you're trying to do with Kussmaul respirations. And then again, you just give sodium bicarb. And sodium bicarb provides a base, which, so this is something that's very important to know. High levels of sodium bicarb will encourage high levels of potassium excretion. And vice versa. High levels of potassium will cause high levels of bicarb excretion. It could happen. It's possible. But this is a big thing to know. If you're giving bicarb, you probably should check potassium because you're excreting it. So there's a warning for hypokalemia. Like we mentioned, do we want to cause hypokalemia? And then your acid-base agents. So big things, right? So sodium bicarb mechanism of action, it brings up your pH, which is what we're trying to do. Treatment of acidosis. The adverse effect is like we talked about in our endocrine. You're over-fixing the solution, and that's a big problem. And that's metabolic acidosis. And typically our signs are going to be an irregular pulse because our body's too excited because of the alkalosis. Slow respirations is big because our body wants to tone it down. Now we have too much in our respirations. We can build up more CO2 in order to balance out the loss of acid because of having too much bicarb. So if we lower our respirations, we'll retain our CO2 and we'll build more up because you're not breathing as much, which is what happens. Like, you have ever hold your breath for too long? You're just building up a bunch of CO2 in, especially any moment you move because you're constantly building. And then cyanosis, because cyanosis is indicative of low, shallow respirations and, just respiratory depression. So obviously, be able to recognize this, and you've got to stop it. It's just that simple. Stop it, and then try to reverse the issue. And then this is just a review of the hyperventilation due to asthma, for alkalosis, prolonged constipation, excess sodium bicarb take, excess use of diuretics that cause potassium loss, severe vomiting. We already went through that. And then the therapy, again, we already talked about this. So nervousness, your body's really up in alkalosis. Your body's stimulated. Nervousness, hyperactive reflexes, your seizures, which again we said is a pinnacle of that of CNS stimulation. Slow, shallow respirations, again, to retain acid. There it is. And then for treatment, if it's that bad, ammonium chloride. If it's kind of mild, sodium chloride with potassium chloride. There you go. And the role of the nurse, right? So
the basics, right?
Basically, a lot of these you kind of should do all the time. You should always monitor your patient. Always provide education, especially talking about what to look out for, what's acidosis, what's alkalosis. Hey, I'm having this. Hey, I'm feeling that. So you want to, we learn that, so we have to tell that to the patient. You always get a medical surgery and home ed drug through the history. That's for everything. Lifestyle and dietary habits, especially those. Hey, I take a lot of antacids. Hey, I've been on this diet that's making me eat a lot of potassium. Or
keto diet?
Yeah, whatever the heck, or things like that. Or keto diets and stuff like that. That's going to cause you to be creating ketones and so on. So just kind of be able to recognize that. Obtain baseline weight and vital signs. We'll always do that. Urinary output, INOs, those are very big. Very, very big. I mean, learn about them so much. So big things always. We know about getting a chemistry panel, your electrolytes, your CBC with your WBCs, which is then your urine specific gravity. That's what you do. Your analysis, same thing. BUN and creatinine for all our muscle functions and making sure nothing's damaged, or for your kidneys. Total protein and albumin, because of those fluids. Remember all the way from the beginning. We want to know our albumin, because that could be causing an issue for your blood pressure. Total protein as well. I mean, you just need to know that as well. Platelet counts and your platelet and prothrombin time as well. I'm not sure what INR is. I'm not too sure.
I'll look it up right now.
Renal and liver function. That's ALT, AST, ALP. Those are the big ones that we already know. Monitor fluid volume status. Same thing. We also have to check, again, urinary output. It's coming up so many different times. That's so big.
International normalized ratio.
Is it for like the tank?
I don't think that's right.
No, it said right. International purpose INR test, monitor anticoagulant therapy.
Oh, okay, that makes sense. Okay. And then assessing neurologic status. I mean, you're supposed to do that at all times, especially if the patient is showing signs of alkalosis, acidosis, or your magnesium changes, or your potassium changes. But big one for your magnesium, because that one causes too much CNS stimulation or depression. And then sodium replacement therapy right here. So pretty straightforward when giving, the role of the nurse when giving sodium replacements. Assess their sodium.
Duh.
Yeah. Assess their electrolyte balance. We know that. Assess for signs of hyponatremia. Again, we covered these. This one, hypernatremia, is the dehydrated guy in the desert seeing things. Hyponatremia is the one where you could have seizures, you could have abdominal pain, you could have shallow respirations,
anorexia.
Yes.
All of them, nausea, vomiting. I want to go over. I mean, it's we went over it. Yeah.
Sodium, monitor sodium levels. I mean, again, urine specific gravity, especially if they're having thiazide diuretics and noise, and their osmolarity too, along with their serum as well. Serum osmolarity and urine osmolarity. You want to know what's the tonicity of the urine or the pee, the urine or blood. Teach the patient to report signs of edema, because that could be indicative of hypernatremia. And then to drink water to replenish. I mean, it's that straightforward. As for potassium replacement, very big one. Monitor for cardiac abnormalities. That's super big. That cannot be emphasized enough. It's contraindicated for people with CKD or people with potassium-sparing diuretics. It's usually contraindicated because if you give them, you're just going to make them have way more, and then you're going to kill them. Same thing. It could be contraindicated for acute dehydration, heat cramps, or patients with digoxin. So digoxin has a lot of interesting things, but if I recall right, digoxin kind of pulls a lot of potassium into the blood, if I recall right. And that's very big, and that can cause a big issue. So just be able to recognize that digoxin can cause potassium toxicity, which is that whole thing with hyperkalemia. And then acute dehydration, I would imagine, is the same thing. Like, have you ever had someone starve? Should they just start eating food like crazy? Probably not. You want to have them eat food slowly. So you probably wouldn't want to give this to someone super dehydrated. I mean, plus, why are you giving a dehydrated person potassium?
Yeah, they should
get.
That
doesn't make sense. Like, why would you give them? And then heat cramps. I mean, that's
just another way.
Dehydration. And then take with meals. I mean, again, what did we learn? Potassium is the horse pill that is kind of acidic, so it can make things worse. So you don't want, it can make things worse by causing irritation and acid buildup and so on. So you want to just take with food, take with milk, in order for them to chill the heck out. And then for sodium bicarb, therapy. I mean, monitor your ABGs because that's the biggest thing. That's going to tell you if the patient is acidotic or alkalotic or anything. And then you have to use it very cautiously for people with renal disease or cardiac disease because it's the same thing. Sodium bicarb, I mean, it's in the name. Sodium's in there. I mean, you have to be careful with cardiac disease and renal. It's just, and you can't get rid of it. But that's something that you like. I even overlook that. It's like at the end, so you're just kind of tired.
Kind of phased out.
Yeah. And then patients should be advised to use alternative over-the-counter meds in order to control, acid reflux or whatever the heck. Because if they use too much Tums or they use something that makes them something that's too alkalotic, that puts them in danger to being in alkalosis. So, try to find other ways. And that's it.